Hi there, our highly valued, treasured and esteemed viewers and listeners, and welcome back to your channel of choice. This video I am about to present was compiled by Dr. Nath Arawa, a clinical pharmacist by training and profession who is the founder of Progressive Pharmacotherapy Consultants, the premier virtual clinical pharmacy institute for capacity building for healthcare workers. A virtual clinical pharmacy institute with a difference, where patient safety, medication therapy management and optimal clinical outcomes are very crucial and non-negotiable to us. Here we seek to remain your premier source of crucial tips for high-impact pharmacotherapy services. So, on behalf of the Institute, I humbly urge you all to sit back and spare me part of your very precious time to share with you very useful tips which may prove very handy in your line of duty. I now welcome you all to part 260 of our pharmacotherapy series, which majors in sexually transmitted diseases. The first question reads: what adverse effects associated with acyclovir, famciclovir, or valacyclovir should be anticipated in a patient who takes the above-mentioned antiviral agents? Overall, all forms of acyclovir, including valacyclovir and famciclovir, are associated with relatively few adverse reactions, largely because of the drug's affinity for viral thymidine kinase over cellular kinase. Hematuria and an increase in blood urea nitrogen and serum creatinine may occur, primarily in patients with underlying renal disease or those receiving concomitant nephrotoxic agents. However, this complication is almost entirely associated with the IV route. In addition, severe local reactions are possible with IV administration. In patients with HIV/AIDS, valacyclovir at a dosage of 8 grams per day was associated with a hemolytic uremic syndrome or thrombotic thrombocytopenic purpura-like syndrome. However, this complication has not been observed with normal therapeutic doses. As described previously, when given intravenously in high doses or with significant dehydration, acyclovir crystallizes in the renal collecting tubules of animals, leading to renal insufficiency. Acyclovir should not be rapidly infused or administered at concentrations greater than 10 mg per milliliter. Dose adjustment is necessary for all 3 antiviral agents in patients with decreased renal function. Although neurotoxicity is a rare side effect, case reports of coma and delirium have been reported in patients with renal failure. Intravenous acyclovir occasionally has been associated with cutaneous irritation and phlebitis, reversible leukopenia and transient elevations of liver transaminases. Oral acyclovir and valacyclovir are relatively safe and do not produce any serious side effects at normal doses. Patients receiving oral acyclovir, valacyclovir, or famciclovir may complain of nausea, dizziness, diarrhea, and headaches. The next question reads: what are the roles for education and counseling in patients with genital herpes? Are other forms of local or symptomatic care useful? Most genital herpes infections are benign, and lesions heal spontaneously unless the patient is immunocompromised or the lesions have become infected secondarily. The patient should be instructed to keep the involved areas clean and dry. To prevent autoinoculation, the patient should be told not to touch the lesions and to wash his hands immediately afterward if he comes in contact with the lesion. Local anesthetics provide relief from the pain of genital lesions, but they should be avoided if possible because they counteract efforts to keep the lesions dry. Local corticosteroid therapy is contraindicated because it may predispose the patient to secondary infections. Patient counseling should include the source contact and any future partner. Healthcare practitioners should attempt to relieve patients' feelings of guilt and anxiety. Discussion of long-term consequences should take place after the acute symptoms of the infection have resolved. For individuals with frequent recurrences, efforts should be made to identify and avoid stimulatory factors such as sunlight, trauma, or emotional stress. The limitations of therapy and the decreased severity and frequency of recurrences with time should be explained to the patient. The periods of infectivity and the need to avoid sexual activity even when lesions are not present should be emphasized, indicating the need for continuous barrier protection. Women with herpes genitalis should be scheduled for routine pap smears and should be instructed to discuss their HSV with their physicians if they become pregnant. Currently, there is no completely effective way to prevent the transmission of HSV-2 infection. Barrier forms of contraception, in particular condoms, may reduce the transmission of HSV, but this may be limited only to male-to-female transmission owing to the large area that herpes lesions may occupy on the woman. However, greater use of condoms by men can increase protection and is recommended to prevent HSV infections. Nonoxynol 9, a spermicide that has in vitro anti-HSV activity, is ineffective in the prevention of established genital HSV infection and may actually increase the risk of transmission of HSV by causing genital ulceration. The next question reads, MFM is a 23-year-old, sexually active female student with a history of frequent and severe recurrences of genital herpes since her initial infection 3 years ago. MFM has tried numerous therapies, including suppressive and episodic antivirals. None of these therapies has provided MFM with any relief of her symptoms, nor have they decreased the frequency of her recurrences. MFM has read much in the lay press about herpes and is concerned about the possible complications of the disease, especially cervical cancer. What are the potential complications of herpes genitalis? Previous research suggested that HSV-2 might be an oncogenic agent responsible for carcinoma of the cervix. However, a large longitudinal nested case control study using nearly 20 years of seroepidemiologic and epidemiologic data combined with a meta-analysis concluded that it is very unlikely that HSV-2 is associated with the development of invasive cervical carcinoma. Severe complications of herpes genitalis include central nervous system disease, such as meningitis and encephalitis, and disseminated disease. The next question reads, CAP, a 26-year-old woman in her 32nd week of gestation, was hospitalized with complaints of painful genital lesions, headache, fever, increased vaginal discharge, and dysuria of 1 week's duration. Multiple ulcerative lesions consistent with genital herpes were present on the cervix, vulva, labia minora, and thighs. How should CAP be treated? Herpes genitalis seropositivity in pregnant women occurs more frequently than in non-pregnant women, with 20% to 30% of all pregnant women having serologic evidence of HSV-2 infection. When HSV is acquired by the mother near the time of delivery, transmission to the neonate can be 30% to 50% but less than 1% in those who acquired it early in pregnancy or had recurrent infection. Unfortunately, a large proportion of those infections occurring during pregnancy are limited to the cervix and are totally asymptomatic, often eluding diagnosis. Pregnant patients with a history of recurrent genital herpes should be examined carefully when they present in labor for evidence of active disease. The safety of systemic acyclovir and valacyclovir in pregnant women has not been established in controlled trials, but the CDC cites the lack of documented fetal harm to assert that acyclovir can be used safely in all stages of pregnancy. Thus, it is reasonable to recommend acyclovir to treat HSV in this patient. Some small studies suggest acyclovir administered for several weeks before delivery may decrease recurrent outbreaks and lessen the need for herpes-related caesarean section, whereas a larger randomized clinical trial did not show a benefit in reducing the need for a caesarean delivery with primary infection. In general, it does seem that patients with symptomatic genital herpes benefit from caesarean section. The manufacturer of Zovirax, that is acyclovir, maintains an extensive database of fetal complications related to acyclovir use. To date, no link between acyclovir and birth defects has been established. The decision to treat HSV with acyclovir during pregnancy should depend on the clinical severity of infection. Fetal exposure data to famciclovir or valacyclovir are limited. If the mother has an active herpes genitalis infection at the time of delivery, either active genital lesions or HSV2 cervicitis, the baby should be delivered by caesarean section within 4 hours after the membranes have ruptured to prevent exposure of the neonate to the virus. However, if no genital lesions are present at the time of labor, vaginal delivery may be recommended. There is evidence that up to 70% of neonatal herpes cases occur in asymptomatic women, and the use of acyclovir or valacyclovir after 36 weeks gestation may decrease clinical disease and viral shedding to the fetus. Neonatal herpes is a devastating systemic infection of the newborn, associated with high morbidity and mortality, especially when infected with HSV2 versus HSV1. HSV is usually transmitted to the newborn during passage through an infected birth canal, approximately 300 times greater than when HSV is not present. The risk of transmission to the newborn is greatest in mothers who acquire an initial infection late in the 3rd trimester and lower in mothers with recurrent infection or those who acquire herpes in the 1st trimester, 25% to 50% versus less than 1% for pre-existing infection. The next question reads, PSL, a 19-year-old woman, presents to the Women's Health Clinic for her annual pelvic examination. 1 week later, her Pap smear is read as showing coilocytosis. A colposcopy is subsequently performed, revealing changes consistent with cervical flat warts. What is the cause of PSL's infection? How should she be managed? Human papilloma virus, abbreviated as HPV, is the cause of genital warts, or condylomata acuminata. Types 6 and 11 account for more than 90% of genital warts. Other types of human papilloma virus, including 16 and 18, account for as much as 70% of cervical cancer worldwide. They are associated with Pap smear changes, including coilocytosis and cervical dysplasia. In the United States, the seroprevalence of human papilloma virus 6, 11, 16, and 18 is 32.5% for women and 12.2% among men aged 14 to 59 years. Cervical intraepithelial neoplasia, abbreviated as CIN, is a common cervical cancer grading system using histologic changes to classify specimens in 3 categories: cervical intraepithelial neoplasia 1, 2, and 3. The higher the number, the greater the chance of progressing to invasive cervical cancer. Most new cases of human papilloma virus infection spontaneously regress, but with progressive histologic changes, the chance of spontaneously regressing diminishes. Cervical intraepithelial neoplasia 1, 60%. Cervical intraepithelial neoplasia 2, 30%. Cervical intraepithelial neoplasia 3, 10%. Types of human papilloma virus are also classified as high risk, or those likely to cause cancer, and low risk, those less likely to cause cancer. Human papilloma virus types 16, 18, 31, 33, 45, 52, and 58 are considered high risk, and types 6 and 11 are low risk, the latter mostly resulting in genital warts. In women, visible warts occur on the labia, introitus, and vagina. Subclinical lesions also commonly occur on these sites and on the cervix, as in PSL's case. They are visible only by colposcopy after applying acetic acid. Men can sexually transmit human papilloma virus infections to women as well as exhibit genital warts, and anal and penile cancer associated with oncogenic human papilloma virus types, especially type 16. The goal of human papilloma virus therapy is the removal of symptomatic warts. Several therapeutic options are available and include patient-administered treatments to visible warts, such as Podophylox 0.5% solution or gel, Imiquimod 3.75% and 5% cream, and Cinecatechins 15% ointment. Provider-administered products include topical treatments, Podophyllin 10% to 25%, trichloroacetic acid 80% to 90%, and cryotherapy, surgery, either laser or scalpel, and intralesional interferon. In a recent meta-analysis, locally applied interferon showed a 44% lesion clearance compared with 27.4% for systemic interferon. Imiquimod induces cytokines and activates the cell-mediated immune system. In initial trials, complete clearance of warts took place in 37% to 50% of immunocompetent patients, but up to 20% experienced recurrence. The 5% cream is optimally applied by finger at bedtime 3 times per week and the 3.5% cream once daily for up to 16 weeks. It is usually left on for 6 to 10 hours before it is washed off with soap and water. Imiquimod may take as long as 8 weeks before warts are cleared. Mild to moderate local irritation occurs in more than half of the patients who use it, especially when used daily instead of 3 times weekly as directed. The cream may weaken condoms and diaphragms. Cinecatechins are green tea extracts that contain active catechins with purported immunostimulatory, antiproliferative, and anti-tumor properties. In the United States, a 15% topical ointment is available. There are limited data on this product, but literature suggests it may be more effective than Imiquimod or Podophylox by clearing up to 55% of external genital warts. It is applied by finger directly to the wart 3 times a day up to 16 weeks, with the most common side effects being local erythema, pruritus, burning, and pain. Cryotherapy by application of liquid nitrogen can be more effective than podophyllin, but it requires special equipment and highly trained personnel. Pain and skin blistering after treatment is common. Cryotherapy is associated with minimal systemic toxicity and is useful against oral, anal, urethral, and vaginal warts. Trichloroacetic acid 80% to 90% is used topically in the treatment of some genital warts, but its efficacy is uncertain. To date, interferons are not recommended because of expense and toxicity. Cases refractory to topical drug therapy should be considered for surgical treatment. Let's briefly talk about its prevention. In 2006, the first vaccine to prevent HPV types 6, 11, 16, and 18 was approved in the United States. This quadrivalent vaccine was tested in women from 15 to 26 years of age and demonstrated 98% to 100% protection against HPV types contained in the vaccine. In males, the quadrivalent vaccine efficacy was 62.1% to 89.4% against genital warts, depending upon previous HPV exposure, leading to its approval for men and boys 9 to 26 years old. Using bridging data, it is estimated that 99% to 100% of 9 to 15-year-olds will seroconvert. In 2014, a 9-valent HPV vaccine was approved to replace the quadrivalent vaccine. The extra 5 types, that is 31, 33, 45, 52, and 58, add 15% more cervical cancer coverage protection to the 66% covered by types 16 and 18 in the quadrivalent. This 3-dose series can be given as early as 9 years of age, but it is CDC recommended at 11 to 12 years as part of a routine adolescent healthcare visit and ideally before commencement of sexual activity. Because there are more than 30 types of HPV associated with anogenital disease, a previous HPV infection is not a contraindication to vaccination. It is also important to note that receipt of the HPV vaccine does not change the recommendation for pap smears. Lastly, it should not be considered a therapeutic vaccine as it has no impact on active HPV infection. Let's briefly talk about vaccines. Prevention and control of STDs have largely revolved around education and antimicrobials. Immunization, however, holds the promise of protecting large numbers of people before they are at risk for STDs as well as targeting those who already have the infection. Hepatitis B is an example of an STD with a highly effective vaccine that is now mandatory for school-aged children. The 9-valent HPV vaccine is gaining momentum and a bivalent HPV 16 and 18 is also approved by the FDA, but the latter is not indicated for prevention of genital warts. Herpes simplex vaccines have been extensively studied, but no candidate vaccine has been submitted for approval. So there you have it, our highly esteemed viewers and listeners, that brings us to the end of this video. If it benefited you in any way, kindly remember to give it a thumbs up, to like it and to share it widely with your peers. Please leave your comments at the bottom. And if you haven't yet done so, I humbly urge you to subscribe to our YouTube channel. I would like to promise you all that the very, very best is yet to come. Thank you very much for viewing this video. On behalf of our senior colleague, Dr. Nath Arawa, I sincerely appreciate your partnership, continued support and kind collaboration. We look forward to interacting with you in the next video, which will be part 261.